Thank you. I do want to thank Drs. Gould, Olschlager, and Wright for the opportunity and privilege of the podium today. So I am a minimally invasive surgeon. I also do, however, perform quite a bit of flexible endoscopic procedures, and my disclosures really are not relevant for the talk today. So I'll start by saying POEM is really here to stay. There are plenty of long-term studies now, mostly single-center, some multi-center, showing efficacy, safety, and it is a better recovery. It's easier to recover from any kind of surgical procedure, including a laparoscopic procedure. Having said that, I think that both laparoscopic hilar myotomy and POEM are both here to stay, and we'll go over exactly why. There may be a slight advantage in POEM with some spastic disorders like type 3 achalasia, for example. We've been doing POEM for spastic disorders for quite a while, and I will say that I've become a little bit unimpressed with the long-term outcomes when you completely take away any kind of motor function from the esophagus. So I think a lot of the studies, we have to be a little bit careful. They look at one 2-year data, but just anecdotally, I can tell you when you start to look out more longer term, those patients still have problems. I also do think that the learning curve is actually shorter for a POEM than some other procedures, including laparoscopic hilar myotomy and fundoplications. We've heard a lot today, just the last lecture, about the importance of technique, and I do think that a fundoplication, a well-done fundoplication, does take practice and repetitions. POEM, I do think, has a shorter learning curve. Marco Patti and his group did publish a nice study back in 2017 where they looked at a comparison between hilar myotomy and POEM and showed that POEM is at least as effective, if actually not slightly more effective, than a laparoscopic hilar myotomy and fundoplication at treating dysphagia, probably because when we do a fundoplication after a hilar myotomy, we do have an opportunity to do it incorrectly or maybe cause dysphagia. In POEM, we do not. But as you'll see at the bottom here, POEM does have a disadvantage. There is more GERD, and there's no question that there is more GERD when you perform a POEM. And here you see almost a 2 times higher incidence of symptoms, 9 times higher rate of erosive disease, and about 4.5 times more objective pH abnormalities. But I do think we have to be careful when we define GERD, and when you read these studies, make sure that you are paying attention to how are we defining GERD. We know that we have to be careful using symptoms as a definition because half of achalasia patients that have been treated with a myotomy and have GERD actually don't feel it. They don't have symptoms. So that's a poor way to define GERD in an achalasia patient. Some will use esophagitis and some use pH studies, and we're going to go a little bit over that. It's also important where you live. If you actually look, and I only have 10 minutes, so I couldn't pull up all the data, but there are some nice meta-analyses that include studies from all over the world. And there is a pretty significant trend in Western countries more likely to have a GERD after a POEM than Asian countries. And we'll discuss a little bit why that may be. But I will say that this top line here, if you look at abnormal pH, this is very consistent. Most studies are going to show 40% of patients after a POEM are going to have reflux. It's very consistent. Most studies will show that. And laparoscopic hilar myotomy, it's usually going to be around 20%, and that's what I quote patients. I do give patients a choice. I will guide them if they need guidance, but for the most part, I give them the options of a hilar myotomy, a POEM. I rarely will recommend Botox unless there's some specific reason. And we have, for the most part, gotten rid of our pneumatic dilation because I do think POEM is better than a pneumatic dilation. But the GERD rate is definitely higher. But I also want to caution people, and those of you in the room who actually do pH studies and read pH studies, and also, even if you aren't performing the pH study, maybe you have a colleague or a gastroenterologist in your group that is doing it, I would caution you and make sure that you're always looking at the tracings. Make sure you understand a pH study if you're going to be doing these procedures. And the reason is because if you do read pH studies, an achalasia patient has a much different type, which will show. And I think that this group from India has done a great job of, and really the only one that I could see that actually focuses on the different types of reflux you can get. after a myotomy for achalasia. And if you look at the top tracing, or A, is kind of a typical reflux tracing. You see a very quick drop to a low pH, and then a quick rise again. But now, if you look down at B, here you have a GERD event, but it does look like an achalasia patient, kind of a quick drop with a long, low pH. But then if you look at C, that's not really reflux, that's fermentation. You have kind of not a quick drop. This is after a meal. You've got kind of a long, drawn-out, low pH, and so forth. And then the last would be kind of stasis of ingested food. So make sure that you're reading the studies. Make sure you really understand when a patient comes to you after a myotomy, whether you've done a laparoscopic hilar myotomy or a POEM, and you look at the tracings and understand, is this truly reflux, or is this an incomplete myotomy? Or is the myotomy complete, but maybe we have more of an end-stage achalasia picture, which is a whole different algorithm. Now, there aren't any good long-term follow-up studies on POEMs yet, so I'm going to use pneumatic dilation data to look at why I think it's important that we identify GERD in patients who've had a POEM and what the consequences could be. And I think these studies here show that you have rates of GERD up to 30%. Again, pneumatic dilation is probably not as effective as POEM, in my opinion. And if you look at some studies, we will see that that's true. But if you look at the bottom here, this is the scary part. So in this study, when we had a mean follow-up of about 9 years, 8% of these patients after pneumatic dilation developed Barrett's, and almost 1%, or about 0.5%, I should say, developed adenocarcinoma, like we typically see for Barrett's. 8 times more likely, by the way, if a hiatal hernia is present, and that's important. I will not do a POEM in a patient with a hiatal hernia, because they are going to get GERD. That patient, for sure, in my opinion, needs a laparoscopic hilar myotomy, fundoplication, and hiatal hernia repair. Dr. Hungness and Soper at Northwestern published a nice paper at the American Surgical, where they actually looked at predictors for GERD, and they found BMI, high BMI, and hiatal hernia. So again, patients with a hiatal hernia, in my opinion, for sure should have a laparoscopic hilar myotomy, and perhaps maybe an obese patient needs something other than a POEM, okay? And why is this the case? Well, again, Dr. Panofino and his group has showed very clearly that as our weight goes up, our abdominal pressure goes up. And why is that important? Well, I do believe that reflux can be defined like Newton's law. And if you look here, the flow rate, or GERD, is directly proportional to the pressure difference between the abdomen and chest. So if we have higher pressure in the abdomen, we're more likely to have GERD. But I will also turn your attention to the diameter here. So the diameter of the EGJ opening. This is also important. And boy, wouldn't it be great if we could do a POEM and we could actually control how much we open the diameter. Well, I'm here to tell you, I don't think we've figured it out yet. I think this was an interesting and very well done study out of China. It was a randomized control trial that just looked at length of myotomy as perhaps a way that we could prevent reflux. And they actually did show a difference. They showed some improvement if you do a shorter myotomy than a standard 6, 7, or 8 centimeter esophageal myotomy. I think a couple things to point out. These were only type 2 patients. And as we know, type 2 patients tend to have still some pressurization. And I do think a longer myotomy where you're taking that pressurization out towards the distal esophagus probably does result in more reflux. Because as I tell patients, we really have 3 defenses against reflux. We have our hiatus, we have our valve, but we also have motility, which is a very underrated defense. We all know GERD is physiologic, but if we have typical motility, we can evacuate those gastric contents quickly and we don't feel bad. And I think in this case, what they're probably showing is that if you can effectively treat the sphincter but not take out any kind of motility just proximal to that, you're less likely to have reflux. So we do actually, at our place, after reading this paper, we do now perform short myotomies of about 3 to 4 centimeters on the esophageal side routinely. I would say 3 we don't do, but we do at least 4 to 5 routinely. Now, the question has come up, and nothing randomized, I would argue, well, I shouldn't say nothing randomized, but in Japan, some studies started to come out, including from Dr. Inoue himself, who we all know was the inventor or the founder for POEM, that showed that actually if you preserve the oblique fibers, that you actually can decrease the amount of GERD that we see post-op. And then the group, I believe the same group that I showed you that was defining pH studies, did a randomized trial that actually showed no difference. Now, there were some questions about whether they truly were preserving the sling fibers. So I think this has yet to be seen, but I actually do believe that maybe there's a chance that we might be able to decrease GERD rates by how far we go on the gastric side and maybe where. But that's just my opinion. But I don't think that's out, we don't know yet. Now, if we do get POEM, what should we do? Well, we've heard from studies earlier, proton pump inhibitors are not as bad as we think, but there are increased risks of certain side effects. And the problem we might have with achalasia patients is because I just told you earlier, they don't have symptoms half the time. And so are they going to be compliant? And when they're not compliant, how often are we going to see erosive disease and perhaps cancer? There is one study with 5 patients who a transoral incisionless or TIF was done in patients who had had a POEM, and they did have 5 out of 5, technical success and also resolved esophagitis at 27 months. I do actually think that there's a possibility here. As Kyle Perry mentioned, TIF doesn't work great because we're not affecting the hiatus, but here's a group of patients whose hiatus in general is okay. So maybe we can think about some endoscopic treatments for these patients. There is some concern about having mucosa only with that stomach, that myotomy being performed. Are we going to maybe cause damage? So I think certainly this would have to be under IRB protocols in my opinion. Now, I'll just tell you before my conclusion what we do. There's no data on medical prophylaxis for GERD after POEM. I just heard from Christy that the AGA may be working on some guidelines. But what we do, and I will just tell you anecdotally, and we are actually looking at, now that we've been out long enough, trying to publish or at least show people our results, we put everybody, whether they have a laparoscopic Heller myotomy and door fundoplication or POEM, everybody is put on a PPI for a year. We then perform on everybody an EGD if they come, which most do, but an EGD, because they want to get off the PPI, EGD and a 96-hour pH study at a year. If that pH study is negative, which it will be 60% of the time, we stop the PPI and we recommend lifelong surveillance because of the increased risk of malignancy. If that pH study is positive, we give patients the options of continuing on a PPI lifelong or perhaps considering either a outpatient laparoscopic door fundoplication or perhaps a study looking at a newer procedure. We also recommend, though there are no guidelines doing this, and I hope the AGA does it, that patients get surveillance at least every 5 years, again, because of the increased risk of malignancy. So, POEM is unquestionably a safe and effective treatment, and I personally think should be considered first-line therapy. I will tell you, after doing hundreds of both Heller myotomy and POEMs, I would have a POEM. I would have a POEM, and I would deal with the GERD if it came, but 60% I'm not going to get it, 40% I will, and I'll have a lot of people in this room, I'll reach out to them, any of them can do my fundoplication. The POEM does result in a faster recovery with equal outcomes to a laparoscopic Heller myotomy, maybe even slightly better. It may be better for spastic disorders. I will just say I caution on long-term results there. POEM does result in reflux rates of about 40%, and that right now there's no proven way to prevent GERD at the time of POEM. There's no consensus on GERD prophylaxis after myotomy, but in my opinion, I think it should be done until objectively ruled out. I used to treat POEM patients symptomatically after POEM. I did not put them on a PPI immediately after the procedure. I did have patients come back 6 months later or a year later saying, my achalasia was treated, I felt great, it's back. And then when you look in, it wasn't that the myotomy was back, but it's actually esophagitis and a stricture that's the problem. So we don't even take that chance anymore, and we don't see strictures anymore because everybody gets a PPI for a year. And then don't forget to screen patients because of the increased risk for malignancy. Thank you.